Okay, so I'm Jason Wilson. This is a second part of a series I'm doing, trying to socially situate COVID. It's a little different than some of the other updates I've given on COVID, that it's not just straight numbers and data, but instead it's sort of the collective experience of the last 6 months from both the lens of a clinical emergency medicine doctor, and also the viewpoint of a critical medical anthropologist. And so this is a talk that I initially did this week for the State Emergency Medicine Conference Symposium by the Sea. That was a long, clunky talk. And so it didn't lend itself well to this type of a format, and also didn't translate out to other audiences. And I have a feeling and a strong responsibility, I think, to give back to the public discourse and with this data and information. And so try to find ways to distill this information back, and so that anybody who's interested can come to the table and be part of this discussion. And so that's the goal of these smaller talks, of chunks of data. And so last night we talked really about just sort of data, but also in a public health intervention setting, trying to map some of the social distancing and transmission mitigation strategies we've done so far onto how they've affected the overall epidemiology of the virus, especially kind of in the Hillsborough County area. Tonight, we're going to get a little bit more to the social sciences, but also into some more data as well, and really concentrate on some of the controversies around data itself. Where do those controversies come from? Why are there controversies? And do those controversies actually even matter? And then some of that controversy has existed around testing and treatment strategies. And then, of course, I think most prominently, a lot of that controversy and conspiracy, other than the fact that there's a lot of conspiracy around whether the virus is a natural occurring virus or not. The other, I think, large area of conspiracy theory is in regards to treatment, and whether or not treatment strategies have been suppressed for political gain, political reasons. So we'll talk about that. And it worked out well that, of course, on Monday, the FDA issued an emergency use authorization. I'll explain what that is in the talk, for convalescent plasma. And so we're going to build into that as we go through this. This one will probably take 30 minutes instead of 20 minutes because this convalescent plasma piece is new tonight. And I think it's important to go through it because it really represents a lot of this back and forth conspiracy and discussion and debate we're having, and really kind of lets us know why it's so important to, as somebody on Facebook said, be kind of boring and dry about this and really understand what the data is that we have in front of us, and try not to sensationalize either way, for good or bad, what we're looking at. And so I'll get into that as we go on. So again, this is where we're going. We talked about data. We're talking about some conspiracies and controversies around treatment, testing, and data itself. We'll talk about masks later this week, the school issue, which is still brewing and still evolving in front of us. The mask issue is too. And then building towards kind of the racism, structural issues around who gets COVID, and what kind of outcomes we see in people who have COVID. And then finishing up with some physician and workforce burnout issues and what we might see in the future after a large disruption like a virus pandemic has given us. So let's jump into this. Just to level set again, this is the data we covered last night. Right now, we're in a period of time where the numbers are looking much better than they did back in July. This gives a little bit of time to reflect, to take a look at some of the data. I'm the principal investigator of a number of clinical trials. So this gives me some time to kind of start looking at where we're at, where we want to go with our COVID research. And I think that's what a lot of people are doing right now, because it's not a great place to be, but we have a little bit of breathing room, with a concern, obviously, as the fall comes in without a vaccine, we may be back in the same place. So that's where we are right now. And so I really want to focus on what I call red herrings, debates that seem to happen on social media and debates that seem to happen on TV that I don't actually really think, at the end of the day, have any bearing on the actual clinical reality or, from the patient perspective, from the patient's reality. Instead, they lend that amount of debate and sort of misinformation that goes on lends itself to an open space. Then that open space gets filled with kind of nonsense, essentially. And so, unfortunately, while we have these debates that probably don't really matter too much, the world kind of creates alternative theories of reality when there's a clinical reality that really could hold true to what's actually going on. And so what I'm talking about specifically are data elements like, what is the true positivity number out there? What is the true case fatality rate? Is it bigger or less than what we actually see? Or, hey, you know, not many people seem to be dying from this, so maybe it's not a big deal. Maybe we should just let it run its course because, you know, the death rate is probably really low because so many people probably aren't really diagnosed. And do we really know how many tests are positive versus how many are repeat positives? And is the Florida state data set the same as the Hillsborough County data set? And what if there's a discrepancy there? I'm going to argue that a lot of this stuff at the end of the day for our patients, other than the fact they get misinformation and follow poor public health advice because of that misinformation, but medically and clinically at the end of the day, it doesn't matter because we have ways to triangulate data. And I think that's a really key point. So 2 key points here. Not only can we triangulate data, we can also watch trends. So trends, and one of the reasons why sometimes people will note that the numbers that they have in front of them don't quite match either my numbers or some other data source is I do try to really follow trends in the data. So things like 7-day averages, 14-day averages, what's going on over a period of time. So that's one important piece. Look at trends instead of the noise that happens every day. Remember, we're 6 months into this virus now, outbreak, pandemic in this area now. We don't have to rely quite as much on everyday stochastic noise. And so if the one lab dumps data one day and the other lab dumps data the other day and it looks like a weird spike, it'll smooth out in the data as we look over months and weeks and weeks now of data. And we can triangulate that data as well. So to get to kind of speak to the big federal debate that's going on, or maybe it's still going on, that the executive branch, the president sort of drives, is this idea of testing versus positivity. You know, but we know that in July, the number of actual cases, not just testing, went up. And we know this because our hospitals were getting full. So that's not a testing problem, right? We still discharge the vast majority of people who have positive for COVID. And so if we're discharging most people with COVID, who are these people who are being admitted to the hospital with new positive COVID tests? They're new positives with new disease who are seeking care because they were sick, not because they had a positive test. The positive test, they'd have still gone home. And so when we triangulate data and we see that the hospitals are filling up with positive patients who are sick and requiring long hospital care, then we know that it's not just a more test problem, but it's a more disease problem as well. And that was really happening. And that's that's the other key point I want to make tonight is while we triangulate data, what we can do with that triangulated data is it gives us the ability to kind of say where we're at. And what I mean by that is the health of the system. And so you may hear commonly that it's not that big of a deal to have this outbreak right now because it only affects 1%, 1.5%, less than 1% of the population. The case fatality rate is whatever it is, 1%, less than 1%, 0.5%, 0.2%, whatever number you want to pick. But the problem is that whatever the real number is, it was enough to come close to breaking our healthcare system. And I think that's the grave reality that we should be debating nationally. The really important thing that we're supposed to be talking about right now is how close we came to completely breaking the healthcare system. And so in this area, we had a little bit of a lead time, right? So if you look at April 19th, here's what I've got data going back to on this graph. We had this kind of period of time where the number of patients with COVID-like illness was not very high. And then it sort of started to really rocket up in June. So we had this period of time to kind of plan. And we did do a good job of planning. Our hospital systems all share data and we got better at treatments. And so things that New York City didn't get, we got. But the reality is that people forget the testing for a second. So whether the test is true or not true, and the numbers are right or not right, people who showed up with fevers and coughs, which is kind of weird for late June, they really skyrocketed. And they weren't just like the flu, right? Because when you look at flu hospitalizations, you don't see this happen in the middle of June and middle of July, or even in January, right? So we also saw a doubling and a tripling of our hospitalizations for people who are presenting with fever and cough. So the key points here are that we can triangulate data. So at the end of the day, whether you want to debate who's at the true positive number or positivity number, it doesn't matter so much when we look at trends over time and we look at triangulated data. Whatever the real numbers are, we know they were too high. We know they were dangerously high. So that's a key point because it really brings out people who get stuck in talking about, well, it wasn't that many people. It's less than 1%, 2%, 3%, whatever of the population, but it was too much. It was so much that we almost broke everything. And we saw it break in New York City. We saw it break. And when it breaks, the case fatality rate skyrockets. And so we don't want to be back there. This is also why we can't run to herd immunity. And so I'm going to talk about herd immunity here in a second. Let's talk about testing first, okay? So testing gets really mixed up in the public discourse. The gold standard test now is what's called a PCR test. It's that's usually the nasopharyngeal swab. There are some other types of PCR tests out there now, but the gold standard would be the nasopharyngeal swab. That test, if there's virus out there, so in other words, if you're in this period of time where this is the blue curve, if you're in this period of time in that week, the 2 week period after, about 2 weeks after symptoms start, it's almost 100%. Like in other words, if you have virus here, it's going to detect it. Okay, so it's going to be like a perfect, test in that sense. Now, there's really no way that you're going to get a false positive test. You're not going to get a false positive test from this. The concern is that if I present in these first 2 weeks, right, or if I present in a week, first week I have exposure, there's a reasonable chance, a pretty high chance I'm going to have a false negative test. And so what we actually know is that from PCR testing, which is the vast majority of the testing being done, we actually know that the numbers reported, whichever data set you pick, the numbers that are reported are less than the actual number of the population because the false negatives are what are high. There really are no false positives for PCR testing. It's the false negatives. So then people get concerned about, well, are the repeat tests getting counted? Are labs that only put the positives in getting counted? It doesn't matter. It washes out in the data for a couple of reasons. And this is a big one. This is a big part of that reason is that some of these people who are really positive, we're not catching anyway. So call it a wash. And the other part of this, the denominator, the number of people who are just first-time testers who have a true positive on the first test is very high. And so no matter what's happening in the numerator, even if you have repeat testers, which should be taken out by the DOH, by the way, but even if you were super concerned there are repeat testers there, they're going to wash out because the denominator, the number of people who have a new positive test is so high. So that's PCR testing. That's the gold standard. That's what's basically reported. The other stuff gets reported separately by DOH. So this is what you're seeing in the data, and it's pretty good data over time. Now, whether you want to use the Hillsborough County data set or the COVID tracker or the Florida Department of Health, they might be off by a little bit because people report data at different times. But over time, the trend will look the same and it will wash out. So this is the PCR testing I talked about. This is, how good it gets basically after a period of time. What about antibody testing? So antibody testing becomes a little bit more problematic, and antibody testing is what I'm talking about here. Now, this is the best antibody testing. This is the Abbott Architect, which is the machine that's in most hospitals. That antibody testing, after about 14 days of having virus, becomes pretty good. It becomes about 100%. And these people are what we call high pretest probability. They're people who are in the hospital probably because they're getting the Architect test. And so it's likely that that's a true positive. Now, the problem that you've heard about, and the problem is with antibody testing, if I go out in the population and not many people have had the virus and I start doing antibody testing, there's a kind of a weird math quirk where the likelihood of that positive test being a true positive for the antibody testing in the community is not very high if the number of people in the community who have the virus is low. So this is just an example. We're not going to go to the math here, but I just want to show you this is true. So what we're talking about is the positive predictive value. How likely is it that a positive test means I really have the virus? And again, this is antibody testing, not PCR testing. PCR testing works really well. But for antibody testing, if only 2% of people have the virus, then my positive predictive value is only 85%. That means I only 85% chance that positive test means I really have the virus. Versus if 10% of the people in the population had the virus, notice my positive predictive value goes up by about 6 points. So that's the problem with antibody testing when there's not many people out there. Imagine if the prevalence was only 0.5%, right? Then it becomes like a flip of the coin, whether that positive antibody test is a true positive or a false positive. But don't get that confused with PCR testing. The PCR testing reported by the state labs is not antibody testing. Those are real positives, and we're underestimating the number of people that are there. Let's stick with antibodies for a second because they're very important. And they go to this concept of, can we run to herd immunity and to R naught? So a lot of people bring up Sweden. Sweden's kind of had a very laissez-faire approach to mitigation strategies and management of the virus with this idea that they could essentially run to herd immunity. So remember that R naught is that reproductive rate of the virus. How many people if you have virus, how many other people will get virus from you? So if we did nothing else, if we did nothing to mitigate virus, that number's about I'm gonna call it 2.35 is what I have here. So it's at 2.35, okay? That means that I'm gonna give the virus to 2.35 people. This is not a static number. This number changes by one, the number of people who've already had infection. So the number of people available to get infected causes this number to go down. And two, it's got some social things to it as well. The more social mitigation I do, the more this number comes down, okay? So when we talk about herd immunity, it's not a static number. If R naught lived at 2.35, herd immunity for this virus is about 60%. Now let me go back to something I said earlier. I said that right now, we know that we almost broke the healthcare system when maybe 1%, 2% of the population had virus. We almost broke the healthcare system, okay? New York City, where, at most, you got some antibody studies that are showing some high numbers in the urban dense area, but probably settles at around 5% or so of the population. So imagine if we skyrocketed that up in a short period of time to 60%, the amount of destruction, forget death for a second. Death's a bad outcome, but so is overloading the healthcare system because that's what leads to an increased slope for death, okay? So this all goes together. We can't run to herd immunity because we will break the healthcare system. Now, as R naught goes down, the number you have to get to for herd immunity also goes down. But the problem is that even the lowest, most conservative estimates for herd immunity put us about 20%. The lowest estimates I've seen put us at 20%. So no one's even claiming that we're going to get to 20%, that we're at 20% or close to 20%. New Jersey and New York are not at 20% or 30, 25%, or, moderate estimates might put us at 30 to 40% right now by a couple different labs out there. We're not even close to that, and look at the destruction we've caused so far. So this comes up to how I kind of start to think about conservatively estimating the numbers in order to really err on the side of the most conservative caution. And what I mean by that is watering down the case fatality rate and increase the number of people who have virus to really kind of get a sense of this. So if we look at antibody testing for a second, that's been done as surveillance, just going out and kind of testing people who have not had virus, but doing surveillance testing. There's been some different numbers out there. Probably the biggest number we've seen is the Santa Clara study, which estimated, well over 20% of the population that they tested may have had, antibody. And the number that they used was to use an 80 times prevalence. In other words, what that means is the number of people we know are positive, we would estimate that 80 times more people actually were positive and divide the case fatality rate by 80. Now, again, I want to go back to something. Even if that's true, people are going to say, see, look, the case fatality rate's very low. And see, look, all these people actually already have virus and are getting closer to herd immunity. Even if that's true, we almost broke the healthcare system. And that's a really important concept to keep on going back to. It doesn't matter what the number you want to model is. The real clinical number didn't work. And it was too high for people to get sick at one time. Now, having said that, now there's been a number of antibody studies done, and we've settled not at 80 times the number, but at 10 times the number. This is a pretty well accepted number now. So what does that mean? It means whatever my actual prevalence is, in other words, if 50,000 people in my population have been diagnosed with COVID, I'm going to multiply that by 10 and say that 10 times that number of people actually had COVID. And that means I could decrease the case fatality rate by 10 as well. That's fine. You can use that if you want to be conservative when you do some modeling. Put the actual number and then that number as like a modeling estimate. That's okay. But again, keep in mind, what are you trying to say? Because at the end point, you got to triangulate your data and remind yourself that the real data for clinical hospital systems was enough that we got to capacity. That's not a myth. That's not a legend. That's not a made up thing. We got to capacity. It was a bad place to be, where we're having to constantly recreate new capacity by finding space in our hospital systems all of the time. That was true anywhere you saw a surge in this country. Okay. This is important because it allows us to plan for events and reopening of schools and what types of events we want to have. So this is called ascertainment bias. This is the idea, how many more people do I want to estimate actually have the virus right now than are diagnosed with the virus. So these are numbers just from a couple of days ago. Even with the decreased incidence rates we're seeing right now, these are pretty current numbers. These are from Saturday or Sunday. I think I ran these numbers. So if we want to say 10 times the number of people in Hillsborough County have the virus and have been diagnosed, that means if you go to a place with 100 people at it right now, there's a 94% chance that you're going to be around somebody who has a current case of COVID. If we drop that ascertainment bias down to 5, in other words, 5 times the number of people have had virus that have been diagnosed, that drops to 76%. But I'd argue that of a group of 100 people, there's with a 76% chance that one of them have current virus is still a pretty reasonably high risk. So that's what this is important for. Okay, coming off of that now, let's move to a different topic, and we'll move in. This will move us into the convalescent plasma, and I do want to spend a couple minutes on convalescent plasma. So first of all, I think the real failure here, the real reason we've seen conspiracy theory mount is a lack of federal and state level consistent messaged leadership. That is a clear reason why we've seen this happen. And I think that's where the failure lies, I think, is the inability to message our public health experts and to just, essentially use our elected leaders and leadership to basically take their message and get it out. That's really what they should be doing. And that's not what we've seen. And so we've seen a couple of things pop up. First and this is also a chance to say, when you're looking at literature, when you're looking at articles, when you're looking at videos, you've got to ask yourself, who are you looking at? Where are they coming from? Unfortunately, just because a person has MD next to their name does not mean that they are trying to get out the best public health information, right? There are rogue, essentially, folks out there who may have a mission to increase their profits in their urgent care center, like these guys from California did. There may be some well-meaning folks in our local community who simply don't follow modern science and practice in a way that is different than allopathic modern medicine. And there may be some folks who may have some mental illness or other problems who've never seen a COVID patient before, by the way, putting out information. So these types of videos have gone viral because they present an alternate reality that is desired. They present an alternate reality that's been left for space. And unfortunately, that space has left doubt in people's minds and has allowed conspiracy to grow. And so what's interesting is that obviously, if you can access information yourself and digest information and be a critical thinker, the likelihood of believing a lot of this information is much lower. So there's a clear, this is a Pew Research study on the right over here. There's clear relationship between education level and the the likelihood of believing in conspiracy theory. There is also a political breakdown of this as well. Although it's high in both parties, I would say. Even in moderate Democrats, it's 1 in 4 people have 24% of the population has some belief in conspiracy theory around COVID being manufactured or having treatment suppressed, and then about 37% of conservative Republicans. So pretty high numbers for conspiracy. And again, I would say driven by a lack of leadership around this subject. So you have to ask yourself, if it's an ER doctor, is this on message with the American College of Emergency Physicians? Is this on message with other information that the vast majority of emergency medicine doctors are saying? If you're in Hillsborough County, for example, you've got a Department of Health that's been very vocal, who's brought doctors to the emergency policy group, to the county commission, has spoken there based on their experiences of leading a large academic healthcare center, seeing hundreds of COVID patients, thousands of COVID patients now, right? Those might be the people you want to listen to, who are doing research, thinking about this information all the time. And essentially, as boring as it sounds, kind of mimicking or saying the same as what you're hearing from other organized public health and medical organizations. I'm not saying there's not room for controversy or discussion, and I'll get to that. Actually, I think that's what convalescent plasma is, and there's actually a very interesting discussion to have in convalescent plasma, but it's been killed or might be killed already by sort of inflammatory conversation instead. So we'll get there. So this is not meant for you to read everything. I just wanted to show you how many times the message around hydroxychloroquine has changed, why this might be. I don't, you know, of all the treatments out there, by the way, I don't know why hydroxychloroquine is the one that became the one that is so rooted in conspiracy, and the one that, you know, is so controversial. You know, there's probably 4 or 5 cheap candidate medicines, I would say, that had a potential role as a prophylactic and a potential role as a treatment medication. Let me just say this to make it really clear. With hydroxychloroquine, I think most of us were very open to the idea of looking at hydroxychloroquine. It's a medicine that's been around for a long time. It's been used in millions of people, very safely. Lupus, malaria, other disease states. Okay, it's been around for a long time. And there was a potential pathophysiological mechanism of how it might work. So it was certainly worth testing, and we did. But you have to, when you're using a medicine for a new indication, you've never used it for, in a new disease state, you should do it as a research trial. And we did that. We did as I was a PI in a research trial. I was a participant in a research trial for hydroxychloroquine. We did that. And what we have found is there was no benefit in sick patients taking hydroxychloroquine. This has been researched. We have looked at this extensively. There's been no prospective randomized controlled trial showing a benefit for patients taking hydroxychloroquine. And there's been a signal for harm. And this gets to a very important point. So the FDA issued an emergency use authorization, which means that I can use hydroxychloroquine, and they're going to ramp up supplies, and people are going to get hydroxychloroquine, kind of like as indicated by the FDA. Now, the problem is that as those trials came out, that emergency use authorization actually got pulled. And so then things got even more weird and more like feeling of controversy, because now there's been an EUA, emergency use authorization, issued and revoked. And what does that mean, right? So now you've got like the FDA sort of getting this like argument with the executive branch, or at least the president, but based on clinical data. And so really where we are right now is that there's no data supporting hydroxychloroquine use. There are some studies that are still going on, and we should certainly let those studies finish, because they're mostly in healthier people or healthcare workers where the signal of harm is not very high. So this continues, and unfortunately, even last night, the president still said, a shame what they did with hydroxychloroquine. But let me just echo again, what they did with hydroxychloroquine was open it up for study, studied it extensively, even issued an emergency use authorization allowing more use of it, saw no benefit, revoked the EUA, and essentially have shut it down. And we're at the place where we should not be using hydroxychloroquine unless you're in a randomized controlled trial. So that background leads us to the last part of this talk, which is the most ongoing current issue, the convalescent plasma issue. So let me just say, convalescent plasma is not a new concept. It's not like a brand new, treatment modality. It's been around for a long time. We get serum from humans. We get serum from other animals. In my snake bite trials, we use serum from, horses and other animals as well. So this is not a new concept. Basically, concept is, one person has a disease, they mount antibody from it, you take that person's plasma that's got the antibody in it, then you give it to somebody else, they benefit from that antibody, right? This has been around for almost 100 years, if not, or around 100 years. And so not new technology, just a new application technology. And I want to make clear too, just in case there's conspiracy theory or anything brewing, I am a supporter of using convalescent plasma therapy at our hospital as part of what's called an extended authorization protocol, and it's part of a research trial at the Mayo Clinic. We've given quite a bit of convalescent plasma. This is a social media post I made in July, asking people, supporting people to come in and donate blood, and so we can take your convalescent plasma and give it to patients who need it. I'm a supporter of doing that as part of a research trial, so I don't have any motive to shut down convalescent plasma. I definitely think this is an area that needs to be looked at as part of research trials. So I just want to make that clear. Now, where do we go from there? So what we have now is the use of convalescent plasma since early April. And the use of convalescent plasma since early April has been done under an extended authorization protocol. So basically that means it's a research study. The FDA said that a couple sites could do the research study and allow other sites to use their protocol. So for example, locally here, there's quite a few hospitals in Hillsborough County that have used the Mayo Clinic protocol. And so you follow the Mayo Clinic protocol, you can send patients, you can give them plasma. Just so you know, it's for sicker patients, patients who are on oxygen, who are got severe COVID and are in the hospital. Now, I will say most other drugs you can give with the convalescent plasmas, like remdesivir, since it's approved now, other hydroxychloroquine you can give with it, but it could keep them out of other research studies. And that's important. We're going to come back to that. So some research studies we have where the benefit of the study drug may be better than convalescent plasma may say if you got another study going on, you can't be in both at the same time. So after late March, early April, we finally ended up with enough data that the FDA could take a look at this and say, you know what, could we move past a research protocol and issue an emergency use authorization? And again, emergency use authorization basically says anyone now can utilize convalescent plasma. Any physician, hospital system can utilize convalescent plasma as long as you meet some criteria we're going to lay out for you. So it moves it off of research and puts it into essentially market. Okay. Now, the FDA looked at that data last week, and as of August 19th, they actually felt the data maybe wasn't strong enough for an issuance of an emergency use authorization. I want to be clear, that doesn't mean we're in the same place we were with hydroxychloroquine, because it's like one study and it wasn't randomized. So I'll get there in a second. What this means is maybe it's just not time for this to go to market. Maybe it's time for us to do more research and to continue it as an extended authorization protocol, or to tweak that and maybe protocolize it. Maybe the NIH steps in and we start doing randomized controlled trials. So that was the discussion that was going on last week. That's a reasonable discussion. Doesn't mean we're going to kill it. It just means that maybe we need to change the way we're doing this to get better data to make sure we can see a signal. Okay. But then Sunday came. And of course, there's no way to get around this, but there's some politics here, right? Monday is the beginning of the Republican National Convention. Sunday comes, there needs to be some kind of big announcement around COVID. This is brewing in the background. So what brews basically is FDA announces emergency use authorization on Sunday night for use of convalescent plasma. Again, a lot of places are using this already, but it's part of research. It's part of an extended authorization protocol. This flips it into market, which means that anyone can obtain the plasma from a blood bank and use it without going through a research protocol. So it brings the drug to market essentially. So why is this a problem? Well, let's talk about this. So we basically have, there's just two issues, okay? The biggest issue is that there's one study, and from that one study, we had, unfortunately, probably an error. I'm just gonna give people the best benefit of the doubt. I mean, when you're Secretary of Human Health and Services, you're probably not reading, you're not reading the actual papers anymore. Someone's probably telling you what the results were. And if I tell you, look, there was a 35% difference in group A versus group B, maybe you screw that up, right? Maybe. The problem is that that message was magnified multiple times by really important people, and it became the message of what the study results were, which is not what the study results were. So I actually think the study is actually okay for what it is. For a beginner study, it's okay. So let me spend just a few more. I know we're over time, but let me spend 5 minutes with this. So problem one is Stephen Hahn of the FDA said that there was a 35% reduction in mortality. And that was echoed by Secretary Azar. 35% reduction in fatality. That's now gone to President Trump. 35% reduction in mortality. So what the problem is that 35% reduction was actually in one of the arms, and it wasn't the more absolute reduction in mortality. It was something called the relative risk reduction. So I'm going to quickly try to cover relative risk reduction versus absolute risk reduction so you can understand what this is. This doesn't mean the study is a horrible study. This doesn't mean that convalescent plasma is bad, but it does mean this is a very damaging statement because listen, there is no intervention that I can think of other than vaccines. There is no intervention in medicine that has a 35% mortality reduction. Okay, so this would be beyond breakthrough. This would be like totally different than anything. This would be like sanitation or vaccination. That would be where we're at. And so there's nothing in medicine that looks like this. Okay, so there's something wrong with that statement. So we're going to talk about what's wrong with that statement here. All right, so the study gets done. It's like 2,800 hospitals. We're one of them, right? So April 4th, July 4th, under this extended authorization protocol, Mayo Clinic, 35,000 units of plasma are given. That's a lot, mostly sick people. And let's look at the results here. So this is it. This is the study. Here's the key. The study is not a randomized controlled trial. That means everyone in the study got plasma. So no drug is going to get approved to go to market unless they do a randomized controlled trial. And if there's no gold standard, then what do you randomize somebody to? Placebo. They get nothing. So in other words, I don't really care if what a jogger versus a runner looks like. I want to know what a walker versus a sprinter looks like, right? I want to know what nothing to something looks like. But here I don't get that. Here I get what people got plasma quickly within 3 days compared to people who got plasma later after 3 days. What was the differences in those two groups? That's what I get here. And that's very different. And so that's number one. That doesn't mean it's a bad study. That doesn't mean there's no signal of benefit for plasma. That doesn't mean we shouldn't use plasma. But that does mean that what was said nationally is very dangerous. That means that saying there's a 35% reduction in mortality where there's nothing in this hypothesis test that could tell you that is very dangerous. It's very dangerous because it leads to the possibility that further study is going to not show that, and then you have to revoke the emergency use authorization. And that puts us in another uncomfortable spot where controversy and conspiracy grow again, because that's what happened to hydroxychloroquine. And we don't want that. You can just state the truth. If you state the truth here, it's actually reasonable truth. So where did the 35% come from? 35% came from this line right here in this little table I made. So you take people who got plasma within 3 days, and you compare them to people who got plasma after 3 days. The people who got plasma with a lot of antibody in the plasma had a 35% relative risk reduction, right? So that means that 9% of those people died compared to 14% of the people in the other group. So 35% less of those people died in those two groups. The absolute risk reduction, which is what should have been reported between the two groups, was 5%. That doesn't sound very impressive, but 5% is actually much more medically appropriate. That's a medical number. That's actually what we think of when we think of treatments. Like it's actually a reasonable number. There's a 5% difference in people who got plasma early versus plasma late. Now, all that means, though, it does not mean there's a 35% mortality. It doesn't even mean there's a 5% mortality reduction in people who got plasma versus those who didn't. The problem here is that what this means is a 5% reduction in mortality of people who got plasma early compared to people who got plasma late. So all we really should have said is that we think that you should give convalescent plasma as early as possible. The biggest benefit signal we see is when people get convalescent plasma early. That's when we see the biggest reduction in mortality. That's all we know so far. And if you had just said that, that's okay. That's okay. It just means we need to study it more. It doesn't mean it's dead. It doesn't mean we shouldn't give it. It means we should actually give it really quickly. We should give it as fast as possible to try to decrease mortality. And we should also we should compare it to a randomized controlled trial to likely a placebo arm with plasma where you keep all the other variables the same. So right now, all we can really say is if I get plasma within 3 days compared to 5 days, every 20 people get plasma in 3 days compared to 5 days, one of those people are going to survive that wouldn't have survived otherwise. Doesn't mean it's dead. It just means it sets us up for a problem when we see data that may not show the same results. And you've also got the public walking around thinking there might be a 35% reduction in mortality. And you've got the potential now for this to sound like a political debate when it's really not a political debate. This is just data. These are just numbers. They were misspoken. The FDA, Han has said that he apologizes. I don't, of course, error retractions are never as strong as the original statement. Also, apologizing this way on Twitter, I would argue, is not a very public apology, meaning if you use words like relative risk and absolute risk reduction without explanation, that's not going to tell anybody anything. You got to say there is not a 35% mortality reduction. We have no idea what the mortality reduction is. We've never compared it to a placebo. What we do know is that giving people plasma earlier within 3 days seems to be better than giving people plasma later. We should study this more, keep on going. That's where we should have been with this. And that's the problem, is it leads us to the potential for more conspiracy theory and more political debate that didn't have to occur. This is a red herring. I'm over time, so I'm going to stop there, and then we'll do masks next time. Thanks a lot for hanging in there.